Hello and welcome to this comprehensive lecture on fetal anomalies in 3D 4D ultrasound. My name is Wael Tohamy and I am proud to be a member of Panaroma Scan team. Together, we are dedicated to advancing knowledge and skills in fetal medicine and prenatal diagnostics. Today, we will explore the fascinating role of 3D and 4D ultrasound in identifying and assessing fetal anomalies. This advanced technology uh, has revolutionized how we approach prenatal care, offering incredible insights and improving outcomes for families and their unborn babies. Thank you for joining us. And let's dive in and discover how volumetric ultrasound is transforming the field of fetal medicine. In this lecture, we will take a detailed look at the application of 3D and 4D ultrasound in detecting fetal anomalies across various systems. By the end of this session, we will have a solid understanding of how volumetric imaging aids in evaluating fetal head and neck anomalies. And this category includes craniofacial abnormalities and conditions affecting the central nervous system. Fetal thoracic anomalies such as congenital diaphragmatic hernia and lung malformations. Fetal abdominal anomalies including defects like Omphalocele or Gastroschisis. Fetal renal anomalies such as kidney malformations and urinary tract obstructions. Fetal spinal abnormalities focusing on conditions like spina bifida and other neural tube defects and sacrococcygeal teratoma. Each topic will highlight the benefits of 3D and 4D imaging in visualizing and diagnosing these anomalies, showcasing real-time cases and practical applications. Let's begin by exploring the first category, head and neck abnormalities. Fetal head and neck are critical area where 3D and 4D ultrasound have brought significant diagnostic advancements. In this section, we will delve into four key conditions: occipital encephaloceles, which is a neural tube defect, where part of the brain and surrounding membranes protrude through an opening in the skull. Congenital hydrocephalus, which is characterized by an abnormal building of cerebrospinal fluid in the brain, leading to increased head size and potential complications. Oropharyngeal teratoma is a rare tumor that can obstruct the airway, posing significant challenges for prenatal management and delivery. Finally, cystic hygroma, where there is a lymphatic malformation often associated with chromosomal abnormalities, particularly in the first trimester. Throughout this section, we will discuss how volumetric imaging enhances our ability to diagnose these anomalies with precision, assess their severity, and guide clinical management. Let's begin with our first condition in the fetal head and neck anomalies, occipital encephaloceles. Occipital encephalocele is a rare neural tube defect where a portion of the brain, along with its surrounding membranes, protrude through an opening in the skull. This opening is typically located at the occipital region. This is the most common area, which is at the back of the neck, of course. Using 3D and 4D ultrasound, we can clearly visualize the extent of the protrusion and evaluate the structure of the protruding brain tissue. This information is crucial in understanding the severity of the condition and planning appropriate management, both prenatally and postnatally. How 3D and 4D ultrasound contribute to the diagnosis of occipital encephalocele. Using 3D ultrasound, we can identify the characteristic sac-like protrusion extending from the posterior aspect of the skull. This sac may contain brain tissues, cerebrospinal fluid, or both. The three-dimensional imaging capabilities provide a detailed view of the defect, allowing us to accurately assess the size of the sac, the extent of the skull defect, and the position of the involved brain tissues. Meanwhile, 4D ultrasound introduces the elements of dynamic imaging. This enables us to observe the movement and behavior of the brain within the sac in real time. It also provides insights into any deformities and their interaction with adjacent cranial structures. Both together, 3D and 4D ultrasound give us a comprehensive understanding of the anomaly, aiding in accurate diagnosis, prognosis, and planning for intervention when necessary. Now let's explore how these key findings guide clinical management. Key ultrasound findings associated with occipital encephalocele. Uh, um, these findings provide critical clues for diagnosis and can be effectively visualized using 3D and 4D ultrasound imaging, as well as 3D, of course. First, there is an abnormal head shape, which is often observed, particularly at the posterior aspect of the skull. This irregularity is a significant marker prompting closer examination of the cranial structures. Second, we may detect visible herniation of the brain tissues, which could involve part of the cerebellum, cortex, or other regions of the brain. Identifying these components within the sac is essential for assessing the severity and potential complications of the anomaly. Finally, there is often an absence of the Roma skull bone contour at the occipital area. This defect creates the opening through which the brain tissue or cerebrospinal fluid protrudes, hallmark characteristics of this condition. These findings, when combined with the imaging clarity offered by 3D and 4D ultrasound, enhance our ability to diagnose occipital encephalocele accurately. In the next section, we'll discuss how these diagnostic insights influence clinical management and strategies. Occipital encephalocele is not always an isolated anomaly. It can often be associated with other conditions that further complicate the clinical picture. These associated conditions may include craniofacial malformations such as facial asymmetry or midline defects, which can coexist with the occipital skull defect. Hydrocephalus, which is characterized by an abnormal accumulation of cerebrospinal fluid in the brain, leading to increased intracranial pressure and enlarged ventricles. Other tube defects, such as spina bifida, which may indicate product disruptions in neural tube development. Recognizing these associated conditions is crucial as they can significantly impact prognosis and management decisions. Advanced imaging with 3D and 4D ultrasound allows us to detect these concurrent anomalies early, providing a more comprehensive view of the fetal condition and informing a multidisciplinary approach to the care. Let's now discuss management prognosis for occipital encephalocele. The prognosis for this condition is highly variable and depends on two key factors: the size of the skull, and the second key factor is the extent of the brain involvement in the protrusion. In cases where minimal brain tissue is involved, the prognosis may be more favorable. However, if critical areas of the brain are included, the condition often leads to more severe neurological deficits. Management typically involves surgical intervention after birth to repair the defect and reposition the brain tissue if possible. This surgery aims to prevent further damage, reducing the risk of infection, and restore the integrity of the skull. Despite surgical advancements, the long-term outcomes vary widely. Some children may achieve a good quality of life with appropriate care, while others may face challenges related to the developmental delay, motor impairments, or other neurological issues that may arise. It's essential to provide families with comprehensive counseling to set realistic expectations and prepare them for the potential outcomes. Early diagnosis through 3D and 4D ultrasound plays a pivotal role in enabling timely planning for delivery and postnatal care. Uh, now we will jump into the next anomaly. To further enhance our understanding of occipital encephaloceles, we have prepared a detailed video presentation. This video will walk you through the condition's key features, including its appearance on 3D and 4D ultrasound, associated findings, and the clinical considerations we have discussed so far. I encourage you to pay close attention to the imaging examples and explanations, as they will bring clarity to how this condition is diagnosed and managed in real-world clinical settings. Let's take a look at the video. Our next condition in this category of fetal head and neck anomalies is congenital hydrocephalus. Hydrocephalus is characterized by the accumulation of cerebrospinal fluid within the ventricles of the brain. This buildup leads to an abnormal enlargement of the ventricles, which can cause increased intracranial pressure that can significantly impact the developing brain, making early diagnosis and monitoring very crucial. Advanced imaging techniques such as 3D and 4D ultrasound allow us to assess the severity of ventricular enlargement and its potential effect on other brain structures. In the next segment, we will explore how these imaging modalities are used to identify and evaluate this condition in details. Let's discuss the role of 3D and 4D ultrasound in diagnosing congenital hydrocephalus. Starting with 3D ultrasound, while it is not typically the first-line imaging technique for this condition, it provides valuable supplementary information. For instance, 3D imaging can help assess the overall shape and volume of the skull. In severe cases of hydrocephalus, for example, we may observe an enlarged head circumference, which can raise suspicion of significant ventricular enlargement. Moving to 4D ultrasound, this modality offers real-time imaging, making it particularly useful for evaluating the structural impact of hydrocephalus. It allows us to visualize the enlarged ventricles and the accumulation of cerebrospinal fluid more effectively. This dynamic imaging can enhance our ability to study the brain architecture, helping to identify secondary effects of the condition on surrounding brain structures. Together, these advanced imaging techniques complement standard diagnostic methods, giving us a more comprehensive understanding of congenital hydrocephalus and its impact. Now let's review the key findings on ultrasound that are indicative of congenital hydrocephalus. One of the primary markers is enlarged lateral ventricles. Measuring the ventricular width is crucial, and measurement exceeding 10 millimeters is a strong indicator for hydrocephalus. This finding serves as a threshold for further investigation and monitoring. In cases of progressive hydrocephalus, we may observe dilatation of the lateral ventricles, which can exert pressure on and lead to changes in the brain parenchyma. This highlights the importance of tracking the condition over time to understand its progression and potential impact on brain development. Additionally, abnormal head circumference growth is another uh, significant finding. An accelerated increase in head size, often detected during routine biometric measurements, may suggest presence of hydrocephalus and warrants a closer look using advanced imaging techniques. Identifying these key findings early is crucial for diagnosis and to guide management decisions. In the next section, we will explore the associated conditions often seen with congenital hydrocephalus. Congenital hydrocephalus can occur as an isolated condition, but it is often associated other abnormalities that can influence both diagnosis and management. Some of the more common associated conditions include aqueduct stenosis, where there is a narrowing of the cerebral aqueduct, which blocks the flow of cerebrospinal fluid and leads to ventricular enlargement. Another example is Chiari type 2 malformation, which is a structural defect in the brain where part of the cerebellum extends into the spinal canal, which can disrupt normal cerebrospinal fluid flow and contribute to hydrocephalus. Another good example is intrauterine infections during pregnancy, such as cytomegalovirus or toxoplasmosis, can damage the brain and lead to abnormal fluid accumulation. Identifying these associated conditions is essential, as they may provide insights into the underlying cause of hydrocephalus and have significant implications for prognosis and treatment. Let's now discuss the management and prognosis of congenital hydrocephalus. Early and accurate intrauterine diagnosis is critical for planning appropriate care. Advanced imaging techniques like 3D and 4D ultrasound play an essential role in identifying the condition and monitoring its progression throughout pregnancy. After birth management typically involves shunt placement to drain the excess cerebrospinal fluid. This procedure helps relieve intracranial pressure and reduces the risk of further complications. The shunt allows for long-term management of fluid accumulation, improving the child's chances of a better quality of life. Prognosis of congenital hydrocephalus vary widely and depends on several factors, including the underlying cause, of course, and the severity of the condition. Cases with minimal brain damage or isolated hydrocephalus tend to have a more favorable outcome. However, when associated with other anomalies or infections, the prognosis may be more guarded. Early intervention and a multidisciplinary care approach are essential in optimizing outcomes for the affected infants and their families. Next, let's move on to the next fetal anomaly in our lecture. The next fetal anomaly we will be discussing is oropharyngeal teratoma. This is a rare benign tumor that develops in the oral or pharyngeal regions of the fetus. Despite its benign nature, it can pose significant challenges due to its size and location, which may interfere with critical functions such as breathing or swallowing after birth. They are unique in that they can consist of a mix of different tissue types, often derived from all three germ layers. For example, these tumors may contain skin, muscle, or even teeth and bone, making them highly heterogeneous in composition. The ability to diagnose this condition prenatally is crucial for planning delivery and postnatal care, as larger tumors may require immediate intervention to ensure the newborn's survival. In the next segment, we will be discussing how 3D and 4D ultrasound play a role in diagnosing this rare anomaly. Let's explore how 3D and 4D ultrasound are utilized in diagnosing oropharyngeal teratomas. With 3D ultrasound, we can gain valuable insight into the location, size, and nature of the mass. This imaging modality provides detailed visualization of the tumor, which may appear as a complex mass extending from the oropharyngeal region. Depending on its composition, the mass may display varying echogenicity, reflecting the presence of different tissue types, which such as bone or muscles or fluid-filled areas. While 4D ultrasound, on the other hand, offers a dynamic real-time perspective. This is particularly useful for assessing how the teratoma impacts surrounding structures, such as the fetal airway or esophagus. For example, large teratomas can cause airway obstruction or swallowing difficulties, which are critical to identify for planning safe delivery and immediate postnatal care. Together, these imaging techniques enhance our ability to diagnose um, and evaluate this rare anomaly, helping to guide delivery planning and treatment strategies. Now let's review the key findings associated with oropharyngeal teratoma on ultrasound. The first notable feature is the presence of a well-defined mass in the oral oropharyngeal region. This mass is typically distinguishable on ultrasound and may vary significantly in size. A hallmark of the tumor is their heterogeneous echogenicity, which reflects the mix of tissue types present. For instance, areas of higher echogenicity might indicate the presence of bone or teeth, while less echogenic regions may represent softer tissues or fluid. Additionally, the mass can cause significant complications. Airway obstruction is a major concern, particularly when the tumor blocks the fetal airway. This can lead to secondary findings such as polyhydramnios, which occurs due to impaired swallowing. In some cases, the tumor may also cause visible displacement of the tongue, further emphasizing its impact on the oral cavity and airway. Identifying these key findings early uh, always allows us to anticipate potential delivery challenges and prepare appropriately for immediate neonatal intervention, which might be needed. Let's discuss the associated conditions and management and prognosis for oropharyngeal teratomas. Starting with associated conditions, in rare cases, oropharyngeal teratomas may be linked to a chromosomal abnormality or other structural malformations. These associations highlight the importance of comprehensive evaluation when a teratoma is detected, as identifying additional abnormalities may influence both prognosis and management strategies. Moving to management, if the teratoma is large or obstructive, it may necessitate an early delivery to ensure the baby's airway can be managed immediately after birth. This is often achieved through a specialized delivery technique, such as the exit procedure, which provides airway support during delivery. Then after birth, the standard approach involves surgical resection of the tumor to remove the mass and alleviate any obstructions or complications it might cause. The prognosis is generally favorable, particularly if the tumor is removed successfully without major complications. Most infants recover well with proper surgical and neonatal care. However, the outcome may depend on the tumor size, location, and any associated anomalies that could impact the baby's overall health. Uh, with these considerations, early diagnosis through advanced imaging is key to optimizing outcomes for affected fetuses and their families. Next, let's move on to the next anomaly in our discussion. The next anomaly we will discuss is cystic hygroma, a congenital malformation of the lymphatic system, presenting as a fluid-filled cystic spaces, most commonly located in the neck region of the fetus. It arises due to blockage or malformation in the lymphatic vessels, which impairs proper lymphatic drainage and leads to formation of these cystic spaces. While the mass is typically benign, its size and location can pose challenges, especially if it obstructs the airway or compresses surrounding structures. Early detection is crucial for planning appropriate prenatal and postnatal management. Next, we will explore how advanced ultrasound techniques assist in diagnosing cystic hygroma. Now, let's understand how 3D and 4D ultrasound contribute to the diagnosis of cystic hygroma. With the 3D ultrasound, we can obtain a highly detailed visualization of the cystic hygroma. These appear as fluid-filled cystic masses or spaces, most commonly located in the nuchal region or the back of the neck. The advanced imaging capabilities of 3D ultrasound allow us to clearly define the structure of the cyst and its relationship to the surrounding tissues. This detailed perspective aids in assessing the size, extent, and potential involvement of nearby anatomical structures. While 4D ultrasound, on the other hand, adds the dimension of real-time movement, which provides additional insights into the dynamic nature of the cyst. For example, if it can help us observe how the cystic hygroma might impact fetal movement or swallowing. These observations are critical in determining the potential clinical implications and planning appropriate interventions. By combining 3D and 4D imaging, we can achieve a comprehensive evaluation of cystic hygroma, which is essential for guiding both prenatal care and postnatal management strategies. To provide a clearer understanding of how cystic hygromas appear on ultrasound, we have included a video showcasing several real-life cases. As you watch, pay close attention to the characteristics of the cystic masses, their location in the nuchal region, and the way they interact with the surrounding structures. Notice the differences in size and complexity between cases, as well as how 3D and 4D imaging bring these findings to life. This video highlights the value of advanced ultrasound techniques in diagnosing and evaluating cystic hygroma. Let's take a look. Let's now go over the key findings of cystic hygroma as observed on ultrasound. The most prominent feature is the presence of a cystic mass located at the posterior neck, which may sometimes extend into the chest. This mass is typically well defined and fluid filled, making it distinguishable on ultrasound imaging. The size and echogenicity of the cyst areas can vary. In some cases, the cysts may be large and multiloculated, meaning it consists of multiple interconnected compartments, which can make its evaluation more complex but definitive diagnosis. Another important finding is the presence of nuchal thickening, often identified alongside an increased nuchal translucency measurement. These features may signal an underlying chromosomal or structural abnormality, emphasizing the need for thorough assessment and a correlation with other findings, proper screening for aneuploidies. Understanding these key ultrasound findings helps guide further investigations and informs potential management strategies. Let's move on to the next section of our lecture. In this section, we will discuss fetal thoracic anomalies. We will focus on two key conditions. Congenital diaphragmatic hernia, which is a defect in the diaphragm that allows abdominal contents to move into the chest cavity. And congenital hydrocephalus, which is a condition characterized by the presence of fluid within the fetal chest cavity. Both conditions have significant implications for fetal development and postnatal outcomes, and we will explore how 3D and 4D ultrasound can assist in their diagnosis and evaluation. Let's begin by defining congenital diaphragmatic hernia. This is a birth defect where there is an abnormal opening in the diaphragm, the muscle that separates the chest cavity from the abdominal cavity. Because of this defect, abdominal organs such as the stomach, intestines, and sometimes the liver can protrude into the chest cavity. The presence of these abdominal organs in the chest can impede lung development, which is a major concern because the lungs need adequate space to grow properly. This restriction often leads to respiratory distress after birth, and the severity of the condition depends on how much the lung development is compromised. Now that we understand what congenital diaphragmatic hernia is, we will look at how 3D and 4D ultrasound are used to diagnose and assess the condition. Let's explore how 3D and 4D ultrasound are used in diagnosis and evaluation of congenital diaphragmatic hernia. While 3D and 4D ultrasound is typically not the first choice for diagnosing CDH, it can still be helpful in visualizing the herniated abdominal organs within the chest cavity. This provides us with a more detailed view of the location and extent of the defect, helping to better understand the severity of the hernia and the surrounding structures. 4D ultrasound, on the other hand, offers as dynamic real-time imaging, which is particularly valuable for assessing the displacement of abdominal organs and the potential impact on lung development. With 4D imaging, we can observe how the herniated organs affect the fetal thoracic space and their potential interference with lung growth. Additionally, it can help us assess the relationship between the heart, diaphragm, and the hernia sac, which is important for planning management strategies after birth, of course. By combining both techniques, we gain a comprehensive view of this complex condition and can better prepare for the postnatal challenges associated with CDH. Now let's go over the key findings associated with congenital diaphragmatic hernia on ultrasound. The first major finding is the herniation of abdominal organs into the chest cavity. The most common location for this herniation is the left side, where the stomach and intestines can be seen. In some cases, the liver may also be involved, although this typically occurs on the right side. Another important sign is the displacement of the heart due to the mass effect of the herniated organs. The heart may be shifted to the opposite side, which in the case of left-sided hernias means the heart will be pushed towards the right. Additionally, the absence of normal diaphragmatic contour is often visible. The diaphragm may appear either absent or abnormally thin in the affected area, highlighting the location of the defect. Finally, in more severe cases, pulmonary hypoplasia can be identified. This refers to underdevelopment of the lungs, which can significantly impact the baby's ability to breathe after birth and contribute to severe respiratory issues. Recognizing these key findings allows us for early diagnosis and management, which are crucial for improving outcomes for affected infants. Let's discuss the associated conditions and management of prognosis for congenital diaphragmatic hernia. CDH may be associated with other anomalies such as chromosomal defects, including trisomy 18, cardiovascular abnormalities, or other congenital malformations. These associations can complicate the clinical picture and may affect overall prognosis, making comprehensive prenatal evaluation even more crucial and critical. When it comes to management, early prenatal diagnosis is essential for planning appropriate postnatal care. In some cases, fetal surgery may be considered as an option, especially if the hernia is detected early and the lung development is not severely compromised. However, most cases of CDH will require postnatal surgical intervention to repair the hernia and support the baby's breathing. The prognosis for CDH largely depends on the degree of lung hypoplasia and any associated anomalies. Severe cases with significant lung underdevelopment often have a poorer prognosis, as the underdeveloped lungs can struggle to function properly after birth. However, mild cases where lung development is less affected may have better outcomes, especially with appropriate respiratory support and surgical correction. With early diagnosing and early intervention, the chances of improving the baby's respiratory function and overall quality of life can be significantly enhanced. Now let's move on to fetal hydrothorax, which is a condition characterized by the accumulation of fluid in the pleural space, which is the area surrounding the lungs within the chest. This fluid buildup can affect one or both sides of the fetal chest. There are several potential causes for fetal hydrothorax. It may result from a lymphatic malformation where there is improper development of the lymphatic system, leading to fluid leakage. It can also occur due to heart failure, where the heart is unable to efficiently pump blood, causing fluid to accumulate in the lungs. Chromosomal abnormalities, such as Turner syndrome, are also commonly associated with hydrothorax. Understanding the underlying causes is essential for determining the appropriate management and assessing the prognosis. Let's take a closer look at how 3D and 4D ultrasound are used to diagnose and monitor fetal hydrothorax. With 3D ultrasound, we can identify the presence of fluid collection within the pleural cavity, providing a detailed view of the chest anatomy, while 3D imaging offers a clearer visualization of chest structures. It is typically used as a complement to standard 2D imaging, of course, which means uh, that 2D remains the primary tool for diagnosis. 4D, on the other hand, allows us to assess the dynamics of the condition, where we can monitor the progression of fluid accumulation over time and observe any associated effects on fetal development. For example, it helps in visualizing any displacement of the lungs or heart, which can be crucial for understanding the severity and potential impact of the hydrothorax on fetal well-being. Now we have a special video prepared for you that will provide a deeper understanding of fetal hydrothorax. This video will give you an up-close look at how the condition presents on ultrasound, including key features to help with diagnosis. We encourage you to pay close attention to the images and explanations, as this will give you valuable insights that will support your learning. Please watch carefully, and we will discuss the key takeaways right after the video. Let's now review the key findings for fetal hydrothorax on ultrasound. The primary feature of fetal hydrothorax is the presence of fluid in the pleural space. On ultrasound, this fluid typically appears as an echoic dark area, which helps us to distinguish it from other structures in the chest cavity. Um, Hydrothorax can involve one side of the chest, unilateral hydrothorax, or both sides, which is called bilateral hydrothorax. Bilateral involvement can tend to be more concerning and may be associated with more severe outcomes due to the increased fluid accumulation. As the fluid accumulates, it can cause displacement of the thoracic structures. Uh, this means that the lungs and heart may be pushed of their normal position to the opposite side, which can further impact fetal development and fetal well-being after birth. In some cases, hydrothorax can lead to hydrocephalus, a condition where there is a widespread fluid accumulation in multiple areas of the fetus, such as the skin, abdomen, and around the heart. Hydrocephalus is often a sign of a more severe presentation and can complicate the management of the condition. Let's take a look at the associated conditions, management and prognosis for fetal hydrothorax. Fetal hydrothorax is often linked with chromosomal abnormalities, including Turner syndrome and trisomy 21. Additionally, hydrothorax can be associated with cardiac or lymphatic abnormalities, intrauterine infections, or maternal conditions, all of which may influence the severity and outcome of the condition. When it comes to management, the approach depends on several factors. The underlying cause of hydrothorax, the size of the effusion, any associated complications if available. In more severe cases, drainage procedure may be considered to relieve pressure and improve fetal well-being. The prognosis for fetal hydrothorax can vary significantly if the condition is non-progressive and is associated with only minor abnormalities. The prognosis can be relatively good, with many babies able to do well after birth with proper care. However, if hydrocephalus is present or if the condition is severe and progressive, the prognosis may be more guarded, and careful monitoring and intervention are crucial for the best possible outcome. Moving on to fetal abdominal anomalies, which include several critical conditions that can affect the development of the fetus. We will begin by discussing Hirschsprung's disease, which is a condition that involves the absence of nerve cells in part of the colon, leading to bowel dysfunction. Next, we will explore Exomphalus major, a condition where abdominal organs such as the intestine are outside the body with a sac and the cord remains attached. We will also cover gastroschisis, which is another condition where abdominal organs are exposed outside the body without a protective sac, often requiring surgical intervention after birth. Then finally, we will look at bowel atresia or obstruction, which refers to conditions where there is a blockage or absence of a portion of the bowel, requiring careful management and sometimes surgical correction after birth. Let's now focus on how Hirschsprung's disease, which is also known as congenital ganglionic megacolon, This is a developmental disorder that occurs when there is an absence of ganglionic cells in the distal colon or rectum. These ganglionic cells are essential for normal bowel function as they control the movement of the intestines through peristalsis, which is the rhythmic contraction that propels food through the digestive tract. Without these ganglionic cells, the affected part of the bowel cannot properly move or propel waste, leading to a functional obstruction in the bowel. This condition can cause significant discomfort and difficulty with bowel movement after birth. Now let's dive into the pathophysiology of Hirschsprung's disease. During embryonic development, neurocrest cells are supposed to migrate and populate in the intestinal wall. In Hirschsprung's disease, this migration fails to occur in affected segment of the colon or rectum. As a result, there is a lack of ganglionic cells in that area, which are crucial for normal function of the bowel. Without these ganglionic cells, the bowel loses its ability to carry out peristalsis or the normal contractions that move food through the digestive tract. This impairment leads to a functional obstruction, meaning the affected bowel segment can't properly relax or contract. As a result, the proximal bowel, the part before the affected segment, becomes dilated as it tries to push contents past the obstruction. Let's talk about how 3D and 4D ultrasound are used to assess diagnosing Hirschsprung's disease. 3D ultrasound is not typically the primary method for diagnosing this condition, but it can be helpful in providing a detailed view of the dilated bowel loops. It allows us to assess their spatial relationship and how they interact with other abdominal structures, giving us important information for diagnosis. 4D ultrasound, which provides real-time imaging, is particularly valuable in evaluating the peristalsis of the bowel. Uh, in cases of Hirschsprung's disease, we may see absent peristalsis in the affected segment, which helps us distinguish this condition from other causes of fetal bowel obstruction. Real-time visualization of the bowel's movement or lack thereof can be a key diagnostic tool. Now let's review some of the key findings of Hirschsprung's disease on ultrasound. The most notable feature is dilated bowel loops. These are fluid-filled loops of bowel that are proximal, which means before the aganglionic segment. These dilated loops result from the inability of the affected segment to propel contents forward. Another common finding is echogenic bowel. The affected bowel may appear hyper-echogenic, which means brighter in the reflectivity of the ultrasound waves. due to the presence of undigested materials or changes in bowel mobility. In more severe cases, amniotic fluid anomalies can be observed, such as polyhydramnios. This is an excess of amniotic fluid, which may be caused by impaired swallowing or decreased gastrointestinal mobility. It's most probably late onset polyhydramnios. Finally, absence of peristalsis is a key diagnostic sign. With real-time imaging using 4D ultrasound, we may see the absence of normal peristalsis in the aganglionic segment, which helps differentiate Hirschsprung's disease from other bowel conditions. Hirschsprung's disease can occur in isolation, meaning it's the only anomaly present. However, it's also seen as part of syndromic conditions, genetic syndromes, which where multiple abnormalities occur together. Some of the conditions associated with Hirschsprung's disease include Down syndrome, which is a genetic disorder caused by an extra chromosome 21. Waardenburg syndrome, a condition that can cause hearing loss, changes in skin pigmentation, and other features. Multiple endocrine neoplasia type 2, a genetic condition that leads to tumors in endocrine glands. Recognizing these associated conditions can be essential in managing Hirschsprung disease, as it may affect the overall treatment plan and prognosis. When Hirschsprung's disease is suspected prenatally, it is important to monitor the fetus carefully, and postnatal confirmation is typically made with a rectal biopsy, which identifies the absence of ganglionic cells. The primary treatment is surgical correction, which involves resecting the aganglionic segment and then reanastomosing the healthy bowel to restore normal function. The prognosis is generally good if surgical intervention occurs in a timely manner. However, complications can arise, including enterocolitis, a severe inflammation of the intestines, and long-term bowel dysfunction, which may require ongoing care. With appropriate treatment and management, most infants can lead normal lives, but follow-up is crucial to monitor for any post-surgical issues. Let's discuss Omphalocele, a congenital condition involving the abdominal wall. An omphalocele occurs when abdominal organs such as the intestines, liver, and sometimes other structures fail to return to the abdominal cavity during development. Instead, these organs remain herniated into the base of the umbilical cord. A key characteristic of an omphalocele is that the herniated organs are covered by a membranous sac, which consists of two layers, amnion on the outer side and the peritoneum on the inner side. This protective sac differentiates omphalocele from other abdominal wall defects such as gastroschisis, which we will discuss later. To understand omphalocele, let's briefly review its developmental context. During normal fetal development, the gut temporarily herniates into the umbilical cord between 6 to 12 weeks of gestation. This occurs to accommodate the rapid growth of the intestines. By the end of the 12th week, the gut undergoes a process of rotation and returns to the abdominal cavity, completing the normal developmental sequence. In cases of omphalocele, this process does not occur as expected. The abdominal contents remain herniated beyond 12 weeks of gestation, resulting in the persistent presence of organs outside the abdominal cavity, enclosed in a protective membranous sac with a cord insertion on top of this mass. This failure of midgut rotation is what underlies the condition we observe clinically as an omphalocele or exomphalus major. When diagnosing omphalocele using advanced ultrasound techniques, both 3D and 4D ultrasound play pivotal roles. With 3D ultrasound, we can achieve detailed surface rendering of the omphalocele sac. This enables us to clearly identify the contents, such as the intestines or liver, and assess the context of herniation. Additionally, 3D imaging is particularly valuable in differentiating omphalocele from other abdominal wall defects, such as gastroschisis, with lack of protective membranous sac. On the other hand, 4D ultrasound provides dynamic real-time visualization. This allows us to observe fetal movements and better understand the relationship between the herniated organs and adjacent structures, offering essential insights for planning and postnatal management. Together, these modalities enhance our ability to evaluate and manage this condition with greater precision. Omphalocele is a midline abdominal wall defect where abdominal organs herniate into a membranous sac at the base of the umbilical cord. One of the key distinguishing features is the presence of this membrane, which differentiates omphalocele from gastroschisis, where the herniated organs are exposed without a covering. The content of the sac can vary. While intestines are commonly involved, larger defects may also include the liver or other abdominal organs, such as stomach maybe. The presence of the liver within the herniation is an important prognostic indicator, as it suggests a more significant defect. Beyond the structural anomaly itself, omphalocele is frequently associated with additional congenital conditions. These include major cardiac defects, chromosomal abnormalities such as trisomy 13, 18, and 21, and syndromes like Beckwith-Weidman syndrome. Therefore, a detailed evaluation using advanced ultrasound techniques, including 3D and 4D imaging, is crucial for assessing the context of the extent of the defect and identify associated anomalies. Crucial part of diagnosing omphalocele is differentiating it from physiological midgut herniation, which is a normal developmental process. In physiological midgut herniation, the bowel herniates into the base of the umbilical cord between 6 and 12 weeks of gestation. These herniated loops are relatively small, involving no covering membrane, and do not include other organs. Importantly, this is a temporary process that resolves spontaneously by the end of the 12th week. On the other hand, in omphalocele, the herniation persists beyond 12 weeks and is more extensive. It may include larger structures such as the liver in addition to intestines, The herniated contents are also covered by a membrane, which is a distinguishing feature of omphalocele. Recognizing these key differences helps us avoid misdiagnosis and ensures accurate evaluation during the critical first trimester period. The management and prognosis of omphalocele required multidisciplinary approach, um, beginning with prenatal care. Serial ultrasound evaluations are essential to monitor fetal growth, amniotic fluid levels, and any associated anomalies that may influence the course of the care. The delivery planning is critical for large omphalocele. A caesarean section may be recommended to minimize the risk of sac rupture during delivery. Postnatal care involves surgical intervention. The goal is to close the abdominal wall defect, which may be done immediately after birth or in stages, depending on the size of the defect, of course. For larger omphalocele, a stacked repair using a silo placement may be necessary to gradually reduce the herniated organs into the abdominal cavity. Prognosis varies significantly. Isolated omphalocele tend to have a better outcome, but cases with associated anomalies such as chromosomal defects or cardiac abnormalities may face more challenges. So accurate prenatal assessment and timely surgical intervention are key to optimizing outcomes. In this section, we will explore gastroschisis, a congenital anomaly of the anterior abdominal wall. This defect is typically located to the right of the umbilical cord insertion and allows abdominal contents, most commonly the intestines, to herniate directly into the amniotic cavity. Unlike omphalocele, gastroschisis is characterized by the absence of a protective membrane, leaving the herniated organs exposed to the surrounding amniotic fluid, which can cause irritation and other complications. This fundamental difference is crucial for understanding its diagnosis and management. Let's delve deeper into the features and implications of this condition. To understand the development of gastroschisis, it is important to consider its embryological origin. This condition arises due to vascular disruption or failure in closure of the lateral body folds during early fetal development. Unlike omphalocele, the abdominal defect in gastroschisis is not covered by a protective membrane, leaving the herniated intestines directly exposed to the amniotic fluid. This exposure can lead to inflammation, thickening of the bowel wall, and potential functional compromise of the intestines. These pathological changes play a significant role in the challenges encountered during postnatal management. When diagnosing gastroschisis, ultrasound imaging plays a crucial role in distinguishing it from other abdominal wall defects, such as omphalocele. Using 3D ultrasound, we can obtain high-resolution surface images that can vividly highlight the herniated bowel loops. This advanced imaging techniques helps confirm the absence of a covering membrane, which is a hallmark of gastroschisis. 4D ultrasound, on the other hand, provides a dynamic, real-time view of the bowel. It allows us to assess critical features such as peristalsis and the presence of complications like volvulus or bowel obstruction. This dynamic evaluation aids in both diagnosis and planning the appropriate management strategy. In such cases, several key features can be identified on ultrasound. The defect is typically small and located to the right of the umbilical cord insertion, often making it easier to differentiate from other abdominal wall defects. Um, you will observe free floating echogenic bowel loops in the amniotic fluid with no covering membrane. This is a distinct characteristic of gastroschisis. Amniotic fluid may appears abnormal, particularly if bowel inflammation is present due to exposure to amniotic fluid. This can also affect the fetal development. Uh, Unlike omphalocele, gastroschisis rarely involves liver herniation or other organs. Uh, the umbilical cord inserts normally into the abdominal wall, separate from the defect, further aiding in distinguishing it from the similar condition. Let's watch this video together. See, two common abdominal wall defects that can be identified during fetal imaging. In gastroschisis, the defect is lateral to the umbilical cord, typically located on the right side. The herniated contacts lack a protective membrane, which differentiates it from Omphalocele. The defect is typically smaller and usually involves only the intestines. Uh, Gastroschisis is rarely associated with chromosomal anomalies, while Omphalocele defect is in the midline and located at the base of the umbilical cord. The herniated contents are covered by a membrane, differentiating it from gastroschisis. Omphalocele tends to be a larger defect, and liver and other organs may also be involved in the herniated contents. Omphalocele is frequently associated with chromosomal abnormalities and syndromes such as trisomy 13, 18, and 21. These differences are critical for accurate diagnosis and management of the condition. The management and prognosis of gastroschisis. In the prenatal period, prenatal monitoring with serial ultrasounds are essential to monitor the condition of the bowel, monitor fetal growth, and follow up on amniotic fluid levels. Maternal polyhydramnios, which may occur as an excess of amniotic fluid due to impaired swallowing. Delivery planning. In most cases, a vaginal delivery may be possible. However, in more complicated cases, a cesarean section may be recommended. It is crucial for delivery to occur at a tertiary center with neonatal surgical capabilities to ensure immediate care. Postnatal surgery after birth, immediate surgical repair is necessary to close the defect and reposition the intestines into the abdominal cavity. Stage repair may be required in cases of larger herniations or if the bowel is compromised. Prognosis with timely surgical intervention, the prognosis for isolated gastroschisis is generally favorable. However, complications such as bowel atresia, volvulus, or infection can impact outcomes. Next, we will discuss bowel atresia or obstruction, a congenital condition affecting gastrointestinal tract. Bowel atresia occurs when there is a complete or partial blockage of the intestinal lumen, preventing the normal passage of amniotic fluid and fetal bowel contents. This anomaly can occur anywhere in the gastrointestinal tract, but it most commonly affects the small intestine, specifically the duodenum, or ileum. Early detection through prenatal ultrasound is essential for planning appropriate perinatal care and postnatal surgical intervention. Types of bowel atresia, each affecting specific regions of the gastrointestinal tract. Duodenal atresia, where there is a blockage in the duodenum. It is characterized by the classic double bubble sign on ultrasound. It is often associated with trisomy 21 and other congenital anomalies. Jejunal-ileal atresia affects the jejunum or ileum and is the most common form of small bowel atresia. It typically results from vascular disruptions during fetal development. They can lead to dilated loops of bowel and polyhydramnios on ultrasound. Colonic atresia is rare form of atresia that involves the large intestine, less frequently diagnosed prenatally, but can present with abdominal distension and delayed passage of meconium after birth. Early detection of bowel atresia is crucial for appropriate tertiary planning and postnatal surgical management. Bowel atresia develops due to disruption in normal fetal intestinal development. There are two primary causes: incomplete recanalization of the bowel during early gestation. The fetal intestine temporarily becomes a solid organ before recanalizing into a hollow tube. If this process is incomplete, a blockage or atresia can form. Vascular accidents, a disruption in fetal blood supply can lead to ischemia and necrosis of a bowel segment, resulting in atresia. This is particularly common in jejunal-ileal atresia. As a result, fluid accumulates proximal to the obstruction, leading to dilated bowel loops visible on ultrasound. The severity of dilatation depends on the level of obstruction and whether peristalsis is still present. Understanding the pathophysiology of atresia helps in predicting complications and planning for postnatal management. Ultrasound plays a crucial role in diagnosing bowel atresia or obstruction, and 3D and 4D imaging provide additional insights. 3D ultrasounds helps in visualizing the spatial arrangement of dilated bowel loops, offering a more detailed anatomical overview. This can assist in differentiating between different types of atresia and evaluating the extent of the obstruction. 4D ultrasound enables real-time assessment of bowel peristalsis. In cases of obstruction, peristalsis may be reduced or absent in the affected segment, helping to confirm the diagnosis. Together, these advanced imaging techniques enhance diagnostic accuracy and aid in prenatal counseling and postnatal planning. The ultrasound findings in bowel atresia or obstruction can provide crucial diagnostic clues. Our first finding can be dilated bowel loops, where there is fluid-filled loops seen proximal to the obstruction, indicating a blockage. Accompanying polyhydramnios, maybe late onset polyhydramnios, um, due to impaired swallowing, commonly seen in gastrointestinal obstructions, of course. Another finding can be the double bubble sign, a classic feature of duodenal atresia, showing a distended stomach and proximal duodenum on ultrasound. Absent or diminished peristalsis, real-time imaging may show decreased bowel movement, differentiating obstruction from other conditions. Echogenic bowel. The bowel may look bright, and this may indicate complications like meconium peritonitis or ischemia. Recognizing these features is key to early diagnosis and management planning. Bowel atresia is often linked to other congenital conditions which can impact diagnosis and management. Duodenal atresia is strongly associated with Down syndrome, occurring in up to 30% of cases, and may also be linked to cardiac defects. Jejunal atresia can be related to cystic fibrosis or result from vascular disruptions during development, leading to ischemic bowel damage. Colonic atresia is rare but may be seen alongside anorectal malformations, requiring a comprehensive evaluation of the lower gastrointestinal tract. Understanding these associations helps guide further testing and prenatal counseling. When evaluating fetal bowel abnormalities, it is essential to differentiate bowel atresia from other conditions with similar ultrasound findings. Bowel atresia is characterized by progressive bowel dilatation, often with fluid accumulation proximal to the obstruction. In some cases, we may also observe echogenic bowel, particularly if the complication like meconium peritonitis are present. Gastroschisis, on the other hand, is distinct because it involves free floating bowel loops outside the abdomen, directly exposed to the amniotic fluid without a covering membrane. Unlike bowel atresia, there is no intrinsic blockage. Rather, the bowel is vulnerable to inflammation and damage from prolonged exposure to amniotic fluid. Another important differential is meconium ileus, which is linked to cystic fibrosis. This condition presents with the echogenic bowel, where thick meconium obstructs the intestines, leading to characteristic ultrasound findings. By carefully assessing bowel dilatation, echogenicity, and fluid patterns, we can differentiate these conditions and guide further evaluation and management. Managing bowel atresia or obstruction begins with careful prenatal monitoring, where regular ultrasounds help assess the condition of the bowel, fetal growth, and amniotic fluid levels. In cases of duodenal atresia, karyotyping may be recommended due to its strong association with chromosomal abnormalities, particularly Down syndrome. When planning delivery, vaginal birth is often possible, but for optimal care, delivery at a tertiary care center with neonatal surgical expertise is advised. After birth, immediate nasogastric compression is performed to relieve pressure in the dilated bowel. Surgical repair follows with techniques such as bowel resection and anastomosis to restore normal function. The prognosis varies depending on the location and severity of the obstruction, as well as any associated abnormalities. In isolated cases, outcomes are excellent with timely surgical management. However, the presence of additional conditions may impact long-term recovery. Early diagnosis and appropriate intervention remain key to optimizing neonatal outcomes. In this section, we will explore fetal renal anomalies, focusing on two key conditions, fetal hydronephrosis and autosomal recessive polycystic kidney disease, Potter type 1, also known as Potter type 1. Fetal renal anomalies can significantly impact kidney function and overall fetal health. Fetal hydronephrosis refers to the dilatation of renal pelvis and calyces due to obstruction or urine flow abnormalities. It is one of the most commonly detected fetal renal conditions and may range from mild to severe, while autosomal recessive polycystic kidney disease is a genetic disorder that affects kidney development, leading to enlarged echogenic kidneys and potential complications such as oligohydramnios and lung hypoplasia. Early ultrasound evaluation is essential for detecting these conditions, uh, assessing severity, and guiding prenatal counseling and postnatal management. Let's take a closer look at each of these conditions, starting with fetal hydronephrosis. Fetal hydronephrosis refers to the dilatation of renal pelvis, which occurs when there is impaired drainage of urine from the kidney. This condition is one of the most common anomalies detected during prenatal ultrasounds and can vary in severity. It can range from a mild and transient condition that resolves on its own to more severe cases that may require further investigation and management. The degree of dilatation and whether it affects one or both kidneys can provide important clues regarding the underlying cause and potential complications. While many cases are mild and resolve without intervention, it is essential to monitor the condition closely throughout pregnancy to ensure the best outcome for both the fetus and the mother. Fetal hydronephrosis can be caused by a variety of conditions, which are classified into obstructive and non-obstructive causes. Obstructive causes, our first one is uretropelvic junction obstruction. Uh, this occurs when there is a blockage at the junction of the renal pelvis and the ureter, preventing normal urine flow from the kidneys. Posterior urethral valve, or PUV, uh, is seen primarily in male fetuses. Uh, this condition causes a blockage in the urethra, leading to urine buildup in the bladder and kidneys. Uretrovesical junction obstruction. This blockage occurs where the ureter enters the bladder, hindering the normal flow of urine. Non-obstructive causes. Vesico-ureteral reflux. This condition involves the backflow of urine from the bladder into the ureter and kidneys, which can lead to renal pelvis dilatation and hydronephrosis. Hydronephrosis as well can be a transient hydronephrosis, which is temporary and often mild dilatation of the renal pelvis that typically resolves on its own as pregnancy progresses. Understanding the cause of hydronephrosis is critical for determining the appropriate management uh, and monitoring strategies during pregnancy. Ultrasound plays a crucial role in diagnosing and assessing fetal hydronephrosis. Both 3D and 4D imaging provide valuable insights into the renal anatomy and function. 3D ultrasound with high resolution imaging capabilities. 3D ultrasound provides a detailed and enhanced view of the renal anatomy, allowing for a more accurate assessment of the renal pelvis and the ureters. This allows us to determine the extent of dilatation and identify any structural abnormalities. For the ultrasound with the real-time imaging capabilities enables us and to dynamically observe renal and bladder functions. It provides insights into the flow of urine and helps us assess any obstruction that may be present. By visualizing the movements and the changes in the fetal kidneys and bladder, 4D ultrasound can aid in distinguishing between obstructive and non-obstructive causes of hydronephrosis. Using these advanced ultrasound techniques allows us to monitor the condition more closely and plan for the appropriate follow-up and management. Let's take a look at some additional findings that can help us evaluate the severity of fetal hydronephrosis. In more severe cases of hydronephrosis, we may observe cortical thinning. This occurs as a result of prolonged obstruction where the kidneys tissue itself begins to lose its normal structure. Cortical thinning is a sign of significant damage to the kidney and may indicate a poor prognosis if not addressed immediately. It is essential to evaluate the bladder, especially in cases where obstruction is suspected. Posterior urethral valve, which is a common cause of obstructive hydronephrosis, may cause a distinctive keyhole sign. This is seen when there is a distended bladder and a dilated posterior urethra. The keyhole appearance is a classic ultrasound finding in male fetuses with POV, and it warrants further investigation and management. Amniotic fluid levels are important consideration. In cases of obstructive hydronephrosis, we may see polyhydramnios if the fetus is unable to properly swallow and absorb the fluid due to renal dysfunction. On the other hand, oligohydramnios, which is more common, can occur if there is significant renal failure or compromised kidney function. These findings help us assess the severity of the condition and guide our management decisions. So it is crucial to keep an eye on both the structural and functional aspects of the renal system. Important associated anomalies that can be found in cases of hydronephrosis. In some cases of isolated mild hydronephrosis, particularly when there are no other obvious structural issues, it is essential to consider the possibility of chromosomal abnormalities. For instance, trisomy 21 can be associated with mild hydronephrosis or pilectasia. Through the hydronephrosis itself, though hydronephrosis itself might not be severe, it is crucial to assess for other signs of chromosomal syndromes in these cases, as early intervention and counseling are often required. Next, we have to look out for more complex syndromic associations. Brown-Bari syndrome, for example, is a condition often characterized by posterior urethral valves, which leads to severe hydronephrosis. The syndrome also presents with a distinctive lack of abdominal musculature, hence the prone appearance. This is not an easy diagnosis to make, but it is crucial in understanding the scope of the condition. On the other hand, renal agenesis can sometimes be present on the contralateral side, with one kidney being severely affected and other absent altogether. These associations remind us that hydronephrosis isn't always an isolated anomaly. It may be a part of a broader developmental issue that requires a more comprehensive approach. So while mild hydronephrosis may seem relatively benign, a thorough investigation of associated anomalies is critical. After all, it's always better to be thorough than to find yourself in a hydronephrotic situation later on. Slide, we will focus on how to differentiate fetal hydronephrosis from other renal anomalies that can present with similar findings on ultrasound. Multicystic kidney disease is a condition where the kidney appears enlarged and contains multiple non-communicating cysts. unlike hydronephrosis, where the dilatation of the renal pelvis are observed. In multicystic dysplastic kidneys disease, the cysts do not communicate with each other or with the renal pelvis. This lack of communication is a key feature that helps distinguish MCDK from hydronephrosis. In polycystic kidney disease, the kidneys are typically enlarged and appear hyperechoic on ultrasound due to the presence of uniformly distributed microcysts. Unlike the large, well-defined cysts of MCDK, these cysts are not visible as discrete entities on ultrasound. Polycystic kidney disease can be more challenging to differentiate because the kidneys can appear normal in early gestation, but as the disease progresses, the kidneys enlarge and the echogenicity increases. Lastly, renal agenesis refers to the absence of one kidney. In this condition, there is no visible renal tissue on ultrasound, and the compensatory hypertrophy of the contralateral kidney may be observed. If the baby has only one kidney, the remaining kidney will often enlarge to compensate for the loss of function. In this case, there will be no signs of hydronephrosis because the remaining kidney is functioning normally, but the overall anatomy will be different from that seen in hydronephrosis. By distinguishing these conditions, you can be better prepared to identify the correct diagnosis and manage the care accordingly. Understanding these differences is critical for accurate prenatal counseling and planning. In this slide, we will discuss the management strategies and prognosis for fetal hydronephrosis. Regular serial ultrasounds are essential in tracking the progression of hydronephrosis. These ultrasounds help monitor the dilatation of the renal pelvis, renal parenchymal integrity, and amniotic fluid levels. It is particularly important to evaluate whether the dilatation is stable or worsening, as this can help predict potential complications after birth. Additionally, monitoring amniotic fluid levels can provide variable insight, as severe hydronephrosis might be linked to changes in fluid paths. Regarding postnatal evaluation after birth, a thorough evaluation is necessary. The first step is often by ultrasound, which is used to confirm the diagnosis and further assess the kidneys. Avoiding cystourethrogram may be performed to check for vesico-ureteral reflux or any other potential obstructions in the urinary tract. This test is crucial in assessing whether urine is flowing backward from the bladder into the kidneys, which can worsen the condition if not addressed. Additionally, renal function tests are important to gauge how well the kidneys are performing and whether there is any impact on overall kidney health. Surgical intervention is often required in cases of significant obstruction, such as uretero-pelvic junction obstruction or posterior urethral valves. These conditions might cause irreversible kidney damage if not treated promptly, and surgery is needed to restore normal urinary flow. Surgical options depend on the type and severity of the obstruction and may involve procedures like pyeloplasty or valve ablation. Prognosis for mild hydronephrosis, the prognosis is generally favorable, and many cases resolve spontaneously without any long-term effects. In fact, transient or mild hydronephrosis, especially when detected early, tends to improve as the fetus matures or after birth. However, in cases of severe hydronephrosis, particularly with bilateral involvement or associated anomalies, the prognosis becomes more complicated. Severe cases can lead to impaired renal function or even pulmonary hypoplasia, a condition where the underdeveloped lungs fail to expand properly due to severe oligohydramnios. These severe cases may require more intensive management and interventions postnatally. The key to improving outcomes is early detection, appropriate monitoring, and timely intervention when needed. Prenatal and postnatal care are both integral in ensuring the best possible prognosis for the baby. Let's discuss ARPKD or autosomal recessive polycystic kidney disease, which is a rare congenital disorder characterized by bilateral enlargement of the kidneys, which occurs due to the macroscopic cystic dilatation of the renal collecting ducts. These cysts are very small but increase in number and size as the condition progresses, leading to the characteristic enlargement of the kidneys. Additionally, it can also affect the liver, leading to congenital hepatic fibrosis. This condition causes a scarring of the liver tissues, which can impair liver function over time. The involvement of both the kidneys and the liver makes ARPKD a particularly complex condition to manage, as both organs are essential for normal fetal development and function. While ARPKD can have a range of outcomes, the severity of the disease often depends on how early it is detected and whether interventions can address complications such as renal failure or liver issues. Let's dive into the etiology and genetics of ARPKD. This condition is caused by mutations in the PKHD1 gene located on chromosome 6. The PKHD1 gene encodes a protein called fibrocystine and polydactin, which plays a crucial role in the development of both the kidneys and the biliary ducts. When this protein is not functioning properly due to genetic mutations, it disrupts the normal development of these organs, leading to the cystic changes seen in ARPKD. ARPKD is inherited as an autosomal recessive pattern, meaning that an individual must inherit mutations from both parents in order to be affected. If both parents carry a single copy of the mutation, there is a 25% chance that the child will inherit both mutated copies and develop the disease. Understanding the genetic basis of ARPKD is essential for both prenatal diagnosis and genetic counseling, as it helps predict the recurrence risk for future pregnancies. Now look at the pathophysiology of ARPKD. The primary feature of ARPKD is the cystic dilatation of the renal collecting ducts, which result in progressive kidney enlargement. As the cysts increase in size, they cause fibrosis in the renal tissue. Over time, this leads to a decline in kidney function and can eventually result in renal failure. In addition to kidney involvement, hepatic involvement is a hallmark of ARPKD. The liver is affected by fibrosis and proliferation of bile ducts, which disrupts normal liver function. This can lead to portal hypertension and other related complications, which can significantly impact the overall health of the individual. As the condition progresses, both renal and hepatic dysfunction contribute to the severity of the disease, and renal failure often becomes a major concern in affected individuals. Dive into ultrasound diagnosis for ARPKD. 3D ultrasound is an excellent tool for assessing enlarged kidneys in ARPKD. It provides detailed volumetric imaging that helps visualize the overall kidney morphology and uniform echogenicity. This can give us a clearer understanding of the cystic changes happening within the kidneys, which are a key feature of this condition. 4D ultrasound takes it a step further by offering real-time imaging. With 4D, we can evaluate the bladder filling, amniotic fluid levels, and also check for any vascular flow abnormalities. The dynamic imaging helps in tracking any changes over time and gives us more insight into how the kidneys and surrounding structures are functioning. This combination of 3D and 4D ultrasound imaging allows for a more comprehensive and nuanced understanding of ARPKD in the fetus. Moving on to the ultrasound findings for ARPKD, here are the most important characteristics we should look for. The kidneys will appear symmetrically enlarged on ultrasound. This is due to the microscopic cysts within the kidneys. They will show increased echogenicity, but the individual cysts themselves are usually too small to visualize clearly. Loss of the corticomedullary differentiation. This is a crucial sign in ARPKD. The kidneys will appear with uniform echogenicity throughout, meaning the distinction between the cortex and the medulla is lost. This is due to the cystic changes affecting both regions of the kidneys. Associated oligohydramnios is common in more severe cases. This is due to the reduced urine output from the kidneys, which impairs the production of amniotic fluid. Bladder size may appear normal initially, but reduced urine production is commonly seen due to kidney dysfunction. Pulmonary hyperplasia is a very known consequence in severe cases, often results as due to the prolonged oligohydramnios. This is particularly concerning if ARPKD is detected early in pregnancy. These findings together are crucial and critical in making the diagnosis and assessing the severity of ARPKD in the fetus. To discuss how ARPKD can be differentiated from other renal anomalies that may present similarly on ultrasound. Multicystic kidney disease typically affects only one kidney and presents with large non-communicating cysts of varying sizes. In contrast, ARPKD is bilateral and shows uniform echogenicity due to the presence of microscopic cysts. The key difference here is that MCDK involves a single kidney and large cysts, while ARPKD involves both kidneys with a more uniform and supple cystic appearance. Autosomal dominant polycystic kidney disease usually presents much later in life and is characterized by the development of larger macroscopic cysts in the kidneys. This condition doesn't typically show up in utero, as it tends to manifest in adulthood. On the other hand, ARPKD presents in utero or early infancy, and the cysts are microscopic
which makes the kidneys appear uniformly echogenic and enlarged, but without visible large cysts. These differences are crucial in helping us making the correct diagnosis and differentiate ARPKD from other renal conditions that may have similar ultrasound findings. Now let's talk about some of the associated findings that are commonly seen in ARPKD. Congenital hepatic fibrosis is one of the key associated conditions. On ultrasound, this may present as an increased echogenicity of the liver, which is a result of fibrosis in the liver tissue. In more severe cases, this condition can lead to portal hypertension, which might also cause ascites, the accumulation of fluid in the abdomen, abdominal cavity. Additionally, splenomegaly or enlargement of the spleen can occur, often secondary to the increased pressure from portal hypertension. Both of these findings are significant and should be carefully monitored in fetuses diagnosed with ARPKD. These associated conditions might highlight the importance of not only assessing the kidneys but also considering the liver and spleen involvement during ultrasound evaluation. Postnatal management of ARPKD primarily focuses on supportive care for the infant renal insufficiency. In severe cases, dialysis may be required to assist with kidney function while awaiting further treatment. Other aspects of management include addressing hypertension, which can develop due to kidney dysfunction, as well as an electrolyte imbalances and hepatic complications related to the associated congenital hepatic fibrosis. In advanced cases with kidney or liver function in advanced cases when kidneys or the liver functions become significantly compromised, transplantation may be necessary to improve the infant's long-term prognosis. The prognosis varies depending on the severity of the condition and the presence of complications. Oligohydramnios and pulmonary hypoplasia seen in early pregnancy can negatively impact survival rates. However, with proper management, some individuals can live into adulthood, although they may experience chronic renal issues. The prognosis of ARPKD is highly variable and is primarily determined by the severity of renal and hepatic involvement. In severe cases where there is significant renal impairment and oligohydramnios detected prenatally, the prognosis is generally poor, with the risk of pulmonary hyperplasia and renal failure in early life. In milder cases where the kidney function is less severely affected, individuals may survive into childhood or even adulthood. However, they may continue to face chronic renal issues and could still require kidney transplantation later in life to manage the long-term effects of the disease. Overall, the prognosis depends on early diagnosis, the degree of kidney and liver involvement, and the management of complications as the individual progresses through life. Section on fetal spinal anomalies focuses on spina bifida and sacrococcygeal teratoma. These conditions can have significant implications for fetal development and are often identified through prenatal ultrasound imaging. Spina bifida refers to a group of neural tube defects where the spinal cord and its protective coverings do not form properly, leading to a gap or opening in the spine. This condition can vary in severity, with the more severe form being myelomeningocele, where both the spinal cord and meninges protrude through the defect. In contrast, sacrococcygeal teratoma is a tumor that forms at the base of the spine, typically in the sacrococcygeal region. It can either be benign or malignant, and often causes mass effect on surrounding structures. Throughout this section, we will review the key diagnostic features, ultrasound findings, and clinical implications of these conditions. Spina bifida is a type of neural tube defect that occurs during early embryogenesis when the neural tube, which eventually forms the spinal cord and brain, does not close properly. This incomplete closure leads to defects in both the spinal cord and the vertebral column, resulting in varying degrees of abnormal spinal development. Spina bifida can be categorized into two main types. The first type is open defects, and these involve a visible opening in the spine and spinal cord, such as myelomeningocele, where both the spinal cord and meninges protrude. Closed defects is the second type. These occur when the spinal cord is not exposed, but there may be other abnormalities in the spinal cord or surrounding tissues. Understanding the type and severity of spina bifida is crucial for management and prognosis. There are three main types of spina bifida, each with varying degrees of severity. Spina bifida occulta is the mildest form of spina bifida, often asymptomatic. There is no visible opening or sac, and typically it is discovered incidentally during imaging for other reasons. The spinal defect is usually small and does not involve the spinal cord. Meningocele is a sac filled with meninges and cerebrospinal fluid, protrudes through the vertebral defect. However, the neural tissue remains contained within the vertebral column and is not exposed. While there may be a visible bulge on the back, it usually does not cause significant neurological damage. Myelomeningocele is the most severe form of spina bifida. In myelomeningocele, the sac contains meninges, cerebrospinal fluid, and neural tissues. This type is associated with significant neurological deficits, which can include paralysis, loss of sensation, and other complications, depending on the location and extent of the defect. The severity of neurological impairment typically correlates with the location and size of the defect. Bifida arises from a failure in the closure of the neural tube between the 3rd and 4th week of gestation. This is a critical period of fetal development where this neural tube, which will form the brain and the spinal cord, fails to completely close. In the case of open spina bifida, the spinal cord and meninges are exposed to the amniotic fluid, which can lead to progressive damage. This exposure can cause further neurological impairment such as sensory loss, motor dysfunction, and even hydrocephalus, as the exposed tissue is vulnerable to mechanical injury and the chemical environment of the amniotic fluid. The degree of damage is largely dependent on the extent of the exposure and the specific spinal level affected. Ultrasound is a key tool in diagnosing spina bifida, and there are several characteristic findings to look for. Spine findings. In open spina bifida, the posterior ossification centers of the vertebrae may appear to be splayed in the transverse plane, which is often described as a U or V shape. This indicates a gap where the neural tube has failed to close properly. Absence of overlying skin. This is commonly seen in open spina bifida, where the skin is missing over the defect, exposing the spinal cord and meninges. The third characteristic finding, we can find a cystic or solid sac of a meningoceal or myelomeningoceal, a cystic or solid sac containing cerebrospinal fluid and possibly neural tissue will often be visible at the site of the defect. This sac protrudes through the vertebral column and can help differentiate the various types of spina bifida. Diagnosing spina bifida, cranial findings, particularly in Chiari-2 malformation, are crucial to assess. These are common in more severe cases of myelomeningoceal. We can detect the lemon sign, which is a characteristic finding in which the frontal bones appear flattened or show a concave shape, which is indicative of abnormal cranial development and pressure from the herniated spinal contents. Banana sign, another finding which refers to the curved appearance of the cerebellum seen on ultrasound due to downward displacement caused by the herniation of the brain structures through the foramen magnum. This sign is strongly associated with Chiari-2 malformation. Ventriculomegaly is another finding where enlarged ventricles can be observed due to obstruction of the cerebrospinal fluid flow, often as a result of the herniated structures blocking normal circulation. This further leads to increased pressure inside the brain. In severe cases of spina bifida, you may observe polyhydramnios or an excess amniotic fluid. This occurs due to cerebrospinal fluid leak from the spine into the amniotic cavity, impaired swallowing functions of the fetus, which can result from neural tube defects like myelomeningoceal. The presence of polyhydramnios may indicate associated gastrointestinal or other neurological issues that hinder normal fluid consumption and processing. 3D ultrasound is invaluable in providing a detailed visualization of the spinal defect and associated sac. This is crucial for surgical planning, allowing for precise assessment of the location and extent of the defect. On the other hand, 4D ultrasound enables real-time imaging, offering insight into fetal movements. This can help detect possible limb deformities such as clubfoot or talipes equinovarus, which is often associated with spina bifida. Both 3D and 4D technologies enhance our ability to monitor and prepare for any necessary interventions post-birth. Sacrococcygeal teratoma is a rare germ cell tumor that arises from the sacrococcygeal region, typically at the base of the fetal spine. It is the most common congenital neoplasm fetuses with an incidence of about 1 in 35,000 to 40,000 live births. Sacrococcygeal teratomas are classified into 4 types based on their internal and external components according to the Altman classification. This classification helps determine the extent of the tumor and plays a key role in the management plan. The tumor's size, vascularity, and potential for malignancy are crucial in evaluating the prognosis and deciding on the appropriate management strategy. (3D and 4D ultrasound play a crucial role in the detailed evaluation of sacrococcygeal teratomas. These advanced imaging techniques offer significant advantages in understanding the tumor's spatial relationships, vascular anatomy, and internal composition. 3D ultrasound provides detailed volumetric images of the tumor, which helps assess its size, location, and the relationship with surrounding structures. 4D ultrasound, with its real-time imaging capabilities, allows for dynamic evaluation, providing insights into the tumor's blood flow and potential complications. 3D ultrasound is invaluable in assessing sacrococcygeal teratomas, offering detailed high-resolution images. Using surface rendering allows clear visualization of the tumor external morphology, helping to evaluate the size and extent of protrusion beyond the fetal body. Using multiplanar analysis provides a precise assessment of the tumor's internal structures, as well as its relationship to the coccyx and surrounding tissue. This helps in understanding the anatomical involvement and planning the approach for surgical intervention. Volume estimation is another essential feature, enabling accurate measurement of the tumor's volume. This is crucial for predicting risks such as the development of high output cardiac failure due to increased vascularity of the tumor that overloads the heart. (4D ultrasound enhances our ability to monitor and manage sacrococcygeal teratomas, particularly in dynamic situations. Real-time monitoring allows for dynamic evaluation of fetal movements, blood flow patterns, and vascular shunting in high vascular sacrococcygeal teratomas. This is essential in understanding the impact of the tumor on fetal circulation and potential complications. Guiding interventions is another key advantage. 4D ultrasound plays a crucial role in planning and performing in utero procedures such as amnio reduction or even fetal surgery when necessary, ensuring the safety and well-being of both the fetus and the mother. Clinical implications of sacrococcygeal teratomas are critical for perinatal management and outcomes. Factors like tumor size, type, and vascularity heavily influence perinatal outcomes. Larger, more vascular tumors are associated with a higher risk of cardiac failure, preterm delivery, and intrauterine fetal demise. These factors help in predicting complications and planning interventions. The detailed insights provided by 3D and 4D ultrasound are invaluable for neonatal surgical planning. These imaging techniques help identifying the precise location, size, and vascularity of the tumor, allowing for more targeted surgical approaches. Monitoring and follow-up with serial ultrasounds, especially in using 3D and 4D ultrasound, are essential for monitoring tumor growth, amniotic fluid levels, and any potential complications. Continuous assessment helps ensure the best outcomes for both the fetus and the neonatal post-delivery. A multidisciplinary approach to managing sacrococcygeal teratoma is essential for optimal outcomes. Effective management involves close collaboration between maternal fetal medicine specialists, pediatric surgeons, and neonatologists. This team work ensures that both the fetus and neonate receive the best care tailored to the specific needs of the case. Prenatal imaging, especially 3D and 4D ultrasound, plays a crucial role in counseling families. It helps in planning delivery and provides vital information for determining post-natal management strategies. Detailed imaging helps identify potential complications early, allowing the care team to be fully prepared. Ultrasound is superior in visualization of fetal anomalies. Enhanced visualization of external structures is one of the standout features of 3D and 4D ultrasound. Surface rendering is one of the key advantages of 3D ultrasound, with its ability to provide lifelike representation of external features. This especially valuable when detecting facial anomalies such as cleft lip and palate and micrognathia. By offering a clear three-dimensional view, it allows for more precise detection than traditional 2D imaging. The 3D reconstructions help in parental counseling by providing parents a realistic view of the anomaly. This can ease their emotional response as they are better able to understand the condition, making it easier to discuss potential treatment options and outcome. With these advancements, 3D and 4D ultrasound plays a crucial role in early detection and communication of fetal anomalies, ensuring a comprehensive and compassionate approach to care. Improved analysis of internal anatomy is another significant advantage of 3D and 4D ultrasound over traditional imaging techniques. Multiplanar imaging. This technique allows us to view a region of interest in three orthogonal planes, axial, coronal, and sagittal planes, which provides a more detailed evaluation of complex anomalies such as spina bifida or holoprosencephaly. By examining these multiple planes, clinicians gain a deeper understanding of the anomaly's full extent and its relationship to surrounding structures. Tomographic ultrasound imaging, or TOI, is a technique akin to CT or MRI. TOI offers a slice-by-slice view of the anatomy, enabling a more comprehensive analysis of internal structures. This provides a clearer picture of conditions that may be difficult to detect or assess with traditional 2D imaging. Both multiplanar imaging and TOI enhance our ability to assess complex fetal anomalies more effectively, ensuring better diagnosis and management. Volume data acquisition is one of the key benefits of 3D and 4D ultrasound that sets it apart from traditional 2D ultrasound. Data storage and offline review. This is one of the advantages of 3D ultrasound, where the volume data acquired during the scan can be stored and reviewed later. This feature is particularly valuable in clinical practice as it reduces the time pressure during patient interaction. It allows for a detailed examination of anomalies without the need to rescan the patient, offering flexibility for thorough assessment and decision making. Clinicians can take their time to analyze the volume data offline, ensuring a comprehensive evaluation and accurate diagnosis. This capability improves diagnostic accuracy and ensures better management of complex cases. Superior detection of subtle anomalies is a significant advantage of 3D and 4D ultrasound in fetal imaging. Enhanced depth perception. With 3D imaging, 3D imaging provides superior depth perception and spatial orientation, which makes it easier to detect subtle cranial malformations such as craniosynostosis or minor limb deformities. These abnormalities might be difficult to identify using traditional 2D ultrasound, but 3D ultrasound enhances the visualization of these subtle differences. It enables clinicians to detect even the smallest anomalies, improving diagnostic accuracy. This capability is essentially important for early intervention and informed decision making, offering better outcomes for both the fetus and the parents. Dynamic imaging with 4D ultrasound allows for the real-time capture of fetal movements, offering an invaluable advantage for detecting functional anomalies. The live 3D images provided by 4D ultrasound enable us to observe fetal movements in detail. This is especially useful for assessing conditions like joint contractures or amniotic band syndrome, where fetal motion is limited or abnormal. The ability to track fetal behavior and activity in real time can provide insight into neurological or musculoskeletal issues, For instance, decreased fetal movement could indicate central nervous system problems, while abnormal limb positioning might point to musculoskeletal anomalies. Overall, 4D ultrasound gives us a deeper understanding of the fetus's well-being and can guide the early detection of potential issues. Assessment of complex anomalies is greatly enhanced by 3D and 4D ultrasound, which provide detailed and accurate views of complex fetal conditions. Congenital diaphragmatic hernia, for example, 3D ultrasound allows us to better visualize the relationship between the thoracic structures and abdominal contents. This enhanced view helps us to assess the severity of the hernia and guides management, especially when planning for surgical intervention after birth. Another example is spinal malformations. These conditions, for example, spina bifida and sacrogenesis, are more precisely visualized using 3D reconstructions, which offer a clearer picture of the extent of the spinal defect and help in surgical planning. By using 3D imaging, we can achieve a more comprehensive understanding of these complex anomalies, ultimately leading to better prenatal counseling and management strategies. Another advantage is improved accuracy in measuring volumes and angles. This is one of the key benefits of 3D ultrasound, as it allows for precise and detailed measurements that are crucial in assessing fetal development and anomalies. For instance, nuchal translucency thickness, head circumference, and volume of specific organs, like the lungs in cases of congenital diaphragmatic hernia, are measured with much higher precision using 3D ultrasound. This enhanced accuracy ensures better detection of anomalies and a more reliable evaluation of fetal growth, allowing clinicians to plan more effectively for management and interventions. With 3D imaging, we can achieve a level of measurement precision that supports better prenatal diagnosis and intervention planning. In rare or complex conditions, showcase the true potential of 3D and 4D ultrasound in fetal medicine. These advanced imaging techniques provide a much clearer spatial understanding of conditions that are challenging to assess with conventional 2D ultrasound imaging. In cases like conjoined twins, facial tumors, or skeletal dysplasias, 3D and 4D ultrasound significantly improves visualization, allowing for better assessment of anatomy and more precise planning. For instance, with conjoined twins, 3D ultrasound enables a detailed view of the areas where the fetuses are joined, helping guide delivery planning and surgical intervention post-birth. In facial tumors, the precise imaging provided by 3D ultrasound allows us to evaluate the tumor size, its location, and potential impact on the surrounding structures. Similarly, in skeletal dysplasias, 3D 4D ultrasound imaging aids in assessing the complex skeletal malformations that may be missed or less accurately portrayed in 2D. Overall, these technologies offer a powerful advantage in managing rare and complex fetal conditions, providing critical insights that influence prenatal care and postnatal outcomes. One of the key advantages of 3D and 4D ultrasound is the ease of sharing and consultation. The digital nature of 3D volumes allows for seamless transfer of data between healthcare providers, making it easier to collaborate on difficult or rare cases. 3D volumes can be shared electronically with specialists across different medical centers or disciplines, ensuring that multiple expert opinions can be gathered without the need for the patient to undergo repeated imaging. This is particularly beneficial for diagnosing rare anomalies where specialized knowledge may be required. Experts from around the world can access and review the 3D imaging, providing valuable insights that help inform management and treatment plans. By enhancing collaboration, these technologies not only improve diagnostic accuracy, but also contribute to better, more personalized care for the fetus. Despite being a cornerstone of prenatal imaging and the gold standard, 2D ultrasound does have its limitation, particularly in complex or challenging cases. One of the main drawbacks of 2D ultrasound is that it captures only one plane of the anatomy at a time. This can make it difficult to fully visualize or detect certain anomalies, especially when they are located in hard-to-reach areas or in complex anatomical regions. In cases where the fetus is in a suboptimal position, the 2D view may not provide clear imaging of the target anatomy, which could lead to missed anomalies or incomplete assessment or rescans. Maternal obesity or low levels of amniotic fluid can further hinder the quality of 2D ultrasound images as well as 3D and 4D, of course, making it difficult to obtain accurate or detailed views of fetal structures. While 2D ultrasound remains invaluable for many aspects of fetal monitoring, these limitations underscore the need for advanced imaging techniques like 3D and 4D ultrasound to enhance diagnostic accuracy. In conclusion, 3D and 4D ultrasound represent a significant advancement in prenatal imaging. These technologies significantly enhance the diagnostic capabilities of conventional 2D ultrasound, especially when dealing with complex fetal anomalies. By providing more detailed and intuitive visualizations, 3D and 4D ultrasound allow for better assessment of intricate structures, improving our ability to detect anomalies early and accurately. They also play a crucial role in parental counseling, offering a clearer understanding of the fetus's condition and helping parents make informed decisions. While 2D ultrasound remains a vital tool, 3D and 4D ultrasound complements it. It ensuring a comprehensive approach to fetal anomaly detection and ultimately improving prenatal care outcomes. Thank you all for attending this lecture and completing this section of our course. We truly appreciate your time and dedication to enhancing your understanding of fetal anomalies and the use of 3D and 4D ultrasound in diagnosis and management. Your commitment to continuing education is crucial in advancing care for expected families, and we hope this lecture has provided valuable insight for your practice. If you have any questions or would like further clarifications, please feel free to reach out. Thank you once again, and we wish you all the best in your ongoing learning journey.